Welcome to our weekly series of cerebrovascular skull-based surgery symposiums every Thursday here from the University of Miami at 5 p.m. This is session 4. This is today, and it is a great pleasure to introduce speakers today. So I'm Jacques Morcos, professor and co-chairman of the Department of Neurosurgery, Otolaryngology, director of vascular and skull base. I am delighted to have as co-directors of this course my partners, Carolina Benjamin, an assistant professor in neurosurgery, specializing in brain tumor and skull-based surgery, and also covering one of our hospital at Jackson North Hospital. Dr. Michael Ivan, assistant professor of neurosurgery, director of research of the University of Miami Brain Tumor Initiative, specializing in brain tumor, skull base, and epilepsy surgery, as well as my two other endovascular and open vascular partners, Robert Stark, assistant professor, co-director of endovascular, and director of endovascular research, as well as Eric Peterson, associate professor and director of endovascular neurosurgery. Of course, we are beaming from Miami, Florida. This is our medical center, and these are our two main hospitals, University of Miami Hospital, Jackson Memorial Hospital. We are, of course, a tertiary referral center for many subspecialties in neurosurgery. Today is our 4th session. As you can see, the link you see at the top would allow you to register for future sessions, and this is a list of the upcoming sessions for the coming several weeks. By going on this link, you will be taken to our website where you can see all of these lists and register and attend. Next week, to give you an announcement, next Thursday will be interesting in that it probably will be in a debate format, approaches to the cavernous sinus tumors. Should the endonasal endoscopic route be preferred? Or should it be transcranial? It will be Paul Gardner and Ali Krisht. Please join us if you are interested in that topic. In parallel to this symposium of Thursday, my partner Mike Ivan has been directing a very successful symposium every Wednesday. So yesterday, for example, next week, what he has arranged is Walter Stummer, who will talk on present and future uses of ALA-derived porphyrins in brain tumor therapy. Please join us as well. It's the same link that takes you to the website, gives you the choice to go either Wednesday or Thursday, or of course, we'd like you to come to both. A big thank you to the people who are making everything happen. Ignacio, who is here running this Symposium on the bottom right, Cristina Sotolongo from Communications, Ingrid Menendez from our Department of Neurosurgery in Education Programs, and Roberto Suazo, the Graphic Design Project Manager. If you are interested in all the educational activities we have to offer, again, that is the link in that yellow box at the top. You can contact me, you can contact Ingrid Menendez in neurosurgical training. As I said, we have a departmental Twitter, Instagram account you can see at the bottom there. Some housekeeping things. Please, audience members, I know you will have questions. Use the Q&A box to send questions. The co-directors with me on this panel, as well as a panelist, we'll try to select some for discussion, and we'll try to cover as many as we can. We are not offering CMEs, at least not yet. If you are interested in getting confirmation email that you attended this, you will anyway automatically in a few days. And of course, if you would like your friends to benefit from these sessions, encourage them by sending our links through your social media. Let me start by introducing our 4 superb panelists for today. I will start first with Jafar. Jafar, a very good friend of mine for many years, and who is a spectacular cerebrovascular microsurgeon, has extensive experience with AVM surgery from NYU, and he will share a case and I'm sure challenge our speakers after their presentations. Edgar Nathal, it's a wonderful opportunity to see you, Edgar, again. Edgar, again, a legendary cerebrovascular surgeon from Mexico at the Instituto Nacional de Reumatología y Neurocirugía and Manuel Velasco Suarez in Mexico. Thank you, Edgar, for joining us. Clement Schirmer, our new leader of the cerebrovascular section, director, comprehensive stroke center, neurosurgeon at Geisinger Health System in Wilkes-Barre in Pennsylvania. Thank you, Clemens, for joining us. And Pablo Rubino, last but not least, from Buenos Aires, neurosurgeon and deputy head of neurosurgery at Hospital de Alta Complejidad El Cruce. If I've massacred that pronunciation, I'm sure he'll correct me later. Pablo is an accomplished neuroanatomist and skull base and vascular surgeon. Now, coming to our two speakers, it is my great pleasure to present first Sepi Amin-Hanjani, who had her MD at Harvard Medical School, did her residency at Mass General Hospital, then did a fellowship in cerebrovascular and skull base in Phoenix at the BNI back in 2004, has been NIH funded and PI in particular of a very impactful study that she's not going to be talking about today, Veritas. And of course, Sepi has always been interested, along with Fadi Charbel, with blood flow and measuring blood flow, and Veritas has to do with posterior circulation strokes. That's for another seminar, another day. She is on the board of director of AANS. She's a past chair of the Joint Guidelines Committee, past chair of the CV section, one of the most eloquent and thoughtful and skilled cerebrovascular surgeons that I know. And I am sure she will deliver a spectacular review of the topic. And the second speaker is Jean deOliveira, all the way from Brazil. You can see his titles: Head Department of Neurosurgery at the Camargo Cancer Center in Sao Paulo. Jean was born, grew up and got his MD at the Federal University of Pará in Belém in Brazil, did his residency Federal University of Sao Paulo, fellowship also at the first in Frankfurt University, cerebrovascular and skull base, then again at the BNI with Spetzler. Jean has been extremely involved in education, particularly in the Brazilian Society of Neurosurgery and in the WFNS, spectacular cerebrovascular surgeon. And I am delighted, Jean, that you are with us today to speak on AVM surgery. So now I will stop speaking and I will ask Sepi to please share her screen and to start her presentation.
So good afternoon or good evening or good morning, depending on where you're listening from. Thank you, Jacques, for that, that introduction. I really appreciate the invitation to be involved in these series of lectures that you and your group have organized. It's a real pleasure to share the stage with Jean especially, and really a nice opportunity to talk about a topic I'm passionate about, as you know. I do want to just mention that I think over the last 15 years or so, I, as probably many of the other panelists and speakers in this series, are used to meeting and talking with Jacques probably at least once every couple of months at various national or international meetings or at various committees, etc. So I'm glad that you've created a format where we can avoid our Jacques Morcos withdrawal syndrome that I was starting to get into. So thank you for that as well to you and your team. So what I've been asked to talk about a little bit today is brain AVMs, relating to natural history and what Jacques had titled Critical Analysis of Published Trials. I think critical in the sense that I'm going to be critical of really the published trial that I think we know is going to be a subject of this talk, which is Aruba. But to start out, I just want to point out I don't have any particular disclosures relevant to this topic. And I really want to acknowledge and thank our entire team here at UIC, what really is a large group of people that are involved in the care of our neurovascular patients. And particularly, of course, Fadi Charbel, who's the chairman here, who has been a longtime mentor of mine and to whom I'm very appreciative for all he has taught me and the opportunities he's giving me in the cerebrovascular realm. And I'll mention our fellow Alfred C., who is graduating this year, and all of our past fellows, and actually our residents too many to name on this slide, but it's really the fellows and residents who not only care for the patients, but also, I think, keep us honest academically as well, challenge our dogmas, and make us explain our philosophy and defend what we're doing and really change our minds over time. And a special recognition to our endovascular team, Ali Alaraj and Gersan Atwal. They're both hybrid neurosurgeon. Gersan right now, as we speak, in fact, is working on an AVM in the OR. And of course, the rest of our related services that work with us. So just an acknowledgement to all of that team as I then go on to discuss a little bit about not just overall management of AVMs, but a little bit about our institutional management of AVMs. So this is really what I'm going to cover over the next 20 minutes or so. I'm going to focus a little bit on natural history and really targeting this talk more towards unruptured AVMs, because I think that's where the controversy in management is the most acute. And discussing a little bit about treatment options to frame the discussion of the published and ongoing trials in this realm. And then just briefly to mention what our approach here at UIC has been to unruptured AVMs, taking all of that into context. So from the standpoint of natural history, I think it's just worth a quick reminder that this is a fairly rare disease. We're talking about a prevalence which is much lower than other conditions we treat as cerebrovascular surgeons, particularly aneurysms, for example, which affect 1 in 50 patients. We're talking about a prevalence of 10 per 100,000, so a very different scale. Despite that, and despite it being a condition that causes only about 4% of all intracranial hemorrhage, it's a significant contributor to ICH in young adults. And I think that's particularly important given the longevity thereafter and therefore the morbidity associated with it being something that's going to affect patients potentially for many, many years, especially because ICH in that context tends to present younger in life, in 20s, 30s, 40 years of age or so. And by far, hemorrhage is the most common presentation of AVMs, followed by seizure. I think we're all very familiar with the phenomenon of headaches as well as of steal phenomenon and neurological deficits, but they are much less frequent. And I think in the headache realm, really my own feeling is that probably occipital AVMs and migraines are associated, but it's really hard to know if other AVMs are truly the source of chronic headaches or not. And rarer finding of incidental, again, given this relatively low prevalence of the condition. Now, what is the risk that an unruptured incidental AVM will present or will demonstrate seizures over time? I think the earlier data from the 1980s suggested that risk was really quite low, about 1% per year. I think the more robust published data in this regard is from prospective information we have from this Scottish intracranial vascular malformation study that studies AVMs and cavernomas, and based on prospective population-based analysis suggests that risk is actually a bit higher. And I think this is a pretty robust rate that one could quote and use in talking with patients in terms of what's their risk of developing new seizures, and the 5-year risk being somewhere around 8%. Now, if you have a seizure with an AVM, then your chances of developing ongoing seizures or epilepsy is quite high. It's more than 50%, but your chance of an incident seizure is going to be about 8% over 5 years. And there's a number of risk factors, mostly from retrospective studies that have been identified that seem to increase the chances of that. Younger age, obviously location, particularly cortical or temporal, larger size. Hemorrhage has been described, but in both directions. So it's hard to know where the truth lies with that. And then some angioarchitectural features as well as high flow and venous congestion seem to increase that risk of seizure. Then, of course, the main thing that we're focused on is the risk of hemorrhage. And I think we're all very familiar with the older studies, particularly starting with the ANDRA study from 1990, looking at a cohort of Finnish patients that suggested that the risk of hemorrhage, all comers, was in this 2 to 4% per year range. And that lent itself nicely to this idea of being able to calculate a lifetime risk of hemorrhage, presuming a 3% annual risk of being 105 minus the patient's age in years. And, you know, when I was training, this was kind of the standard way we thought about, well, what's the risk for a given patient that they're going to have a hemorrhage in their lifetime? Since that time, over the development of more prospective databases, data started to come out that suggested that that risk might be quite a bit lower than that high 3 to 4% per year, and even less than 1% per year, but depending on certain features that may increase the risk of hemorrhage versus keep it at a much lower standard level. And that if you didn't have the risk factors like deep location or deep drainage or prior hemorrhage, that the risk of a given AVM might be significantly lower than that 3 to 4% per year. And there are a number of features, again, mostly from retrospective studies, but also from some of these prospective databases that have referenced all of these angioarchitectural features as potentially increasing the risk. And you'll see that in some cases, the descriptions have been contrary to each other. Some series describing small size as a risk, some large size. I think the preponderance suggests that smaller size, deep drainage, intranidal aneurysms, and particularly venous outflow restriction or single draining vein are things that angioarchitecturally can be indicators of higher risk of hemorrhage. And there are certain lesion features such as deep or infratentorial locations in particular, as well as, of course, prior history of rupture that seem to increase risk of subsequent hemorrhage. And certain patient features, again, some studies that describe contrary findings, but at least in terms of seizures, hypertension, age, and a lot of controversy and conflicting data in the literature about pregnancy and its role in increasing risk of hemorrhage. Some recent studies suggesting that it does, an even more recent systematic review by Michael Morgan's group that suggests that based on the way these different studies have looked at the risk period around pregnancy or not has not been very consistent, and it's just probably we don't know truly if there is an increased risk or not during pregnancy. My own suspicion and practice has been to consider that a higher risk period, but I acknowledge that the data in the literature does not support that strongly because of the design of these really all retrospective studies looking at that question. So where do we stand with what are truly hemorrhage rates or hemorrhage risks? This is a table from the AHA scientific statement that looked at and discussed unruptured AVMs. And looking at a number of the recent studies, the range of hemorrhage rates is really more in that 1 to 2% per year range. And I'll just note that this study, Moore et al., is Aruba, which we'll discuss in a little bit more detail shortly, that really showed this about 2% per year risk of hemorrhage. What sometimes gets lost in the discussion of hemorrhage with AVMs, especially by non-interventionalists or proceduralists, is the notion that these hemorrhages are not benign. It's not as morbid and fatal as subarachnoid hemorrhage from aneurysmal source, and yet it is still a very morbid and fatal event. 10 to 15% mortality from an incident hemorrhage, your first hemorrhage, and a high rate, a third of patients ending up with significant functional disability. So it is not a trivial thing to wait till an AVM bleeds. They're not always going to be fatal. They're not always going to result in functional deficit, but in a significant proportion of patients, they may well do. So what are our options in this setting? Well, expected management, wait and see, conservative therapy, whatever you'd like to call it. It's interesting to note that there is some lines of research, though, that are going beyond the just kind of do nothing, which is in terms of medical therapies. And this was a nice recent review by Adib Abla and Dan Cook at UCSF that talk a little bit about some of the agents that people are interested and are pursuing in looking at AVMs in terms of treatment to reduce risk of hemorrhage. Things like VEGF inhibitors, matrix metalloprotein inhibitors to try and stabilize AVMs and reduce risk of hemorrhage. All of these are minimally studied, I would say. Bevacizumab is in a phase 1 study or had been recently, but nothing that's emerged to any degree that I think it's permeating or will soon permeate our current care, but something to keep an eye out for in the future. In the absence of that, we're really talking about interventions that are attempting to really obliterate the AVM surgically, radiosurgically, or with embolization. And if you look at the published data, if we go back to a Cochrane review from 2010, at that time, really up to 2010, there was no randomized data to support any of those particular treatment options against each other or against conservative management. And really what came thereafter was Aruba. And Aruba, as I think everybody who's on this panel and probably most of the people listening to this symposium are well aware of, was a randomized multi-center trial looking at intervention versus any medical management versus any intervention, and for a relatively short period of follow-up, 5 years, focused on unruptured, but not necessarily asymptomatic AVM. So patients with headaches, seizures, etc. were eligible. And the goal of that study was to enroll 800 patients, but it was ultimately adjusted to 400 because of some recruitment issues that we'll talk about in a moment. And at the same time that that study was stopped early and published, also a analysis of an observational study, again from the Scottish Intracranial Vascular Malformations collaboration, which was just a prospective observational study, also was published, both in 2014. Both of them really concluding the same thing, that intervention shouldn't be done, essentially, that medical management was superior based on Aruba as a randomized study and in the Scottish study in terms of an observational cohort. Now, I'm going to focus mostly on Aruba as the randomized study as the higher level of evidence, because as we know, observational studies can have a lot of intrinsic selection bias in terms of who is and isn't intervened on. But either way, really in 2014, New England Journal, this was the conclusion that they were proposing in the Journal Watch is, until there's more data, it's difficult to justify any intervention for unruptured AVMs at all. And the question is that really the right conclusion to arrive at after Aruba? And certainly there was a lot of pushback from the cerebrovascular section and various societies and many individuals about why that may not be the correct conclusion. I'm really going to point out, though, that the first of these editorials on this topic was published in 2012. So that was before Aruba was reported, and that's because there was already concerns about the design of the study long before even the results were posted. So it wasn't just an after the fact, we don't like the results. It was more of a priori, we don't like the design of this study that was noted here. So, why was that? I think it's worth reflecting a little bit on some of the factors that Aruba did not take into consideration well, which is that these modalities of treatment have different risks and efficacy. And if you look just in a very generic way, you might say, as this meta-analysis of treatments did, that the risks are very similar amongst these modalities, but the ranges are incredibly wide, and there's multiple patient and AVM factors that would influence that. So I think we all know that for surgery, Spetzler-Martin grade or variations thereof has been very useful in distinguishing which AVMs are suitable for surgery. Grade 1s and 2s very suitable, grade 4s and 5s not very suitable, grade 3s in a gray zone, and even amongst grade 3s, there's ones that are more or less suitable for surgery. So there's a lot of differentiation among different AVMs in terms of which treatment, even surgically alone, would be appropriate. And similarly, that's true for other treatments. But if you look at the Spetzler-Martin grade, that's really over time borne out as being a good predictor. 1 and 2 Spetzler-Martin grade AVMs do very well with surgery. And in the newer Spetzler-Ponte classification, where you really can just lump these together, that tier of patients really do very well surgically, as has been shown in other series over time. Now for radiosurgery, those are going to be optimal for somewhat different lesions, the more deep-seated or near eloquent lesions, but they have a different time lag towards the efficacy of that bearing out. They have different treatment complications that have somewhat overlapping features with Spetzler-Martin, but not exactly the same. Here, I'm just showing one of the many or a couple of grading scales that can be used to look at the risk stratification for radiosurgery. And similarly for embolization, complication rates vary in different series. And if you look at prognostic risk scores, and this is a shout out to Bobby Stark since he's one of the organizers of this. This is a risk score he published in 2009 that helps predict what's your risk of intervention with embolization. So there's differential risks and differential ways of determining any particular AVM's risks for each of these modalities. And beyond that, the obliteration rate and the efficacy of the treatment is very different, with surgery by far having the highest cure rates overall, you know, as well evidenced even in meta-analyses and systematic reviews. But of course, for a given AVM, embolization may be completely curative. But in general, surgery is going to be your highest chances of actually obliterating the lesion. So going back to Aruba, you know, did it take these things into account? It was halted early after 226 patients instead of their target of 400. You'll note that it included a wide range of Spetzler-Martin grades. At least generically, one would assume that 3s and 4s are at high risk of complications. And so I would say these were overrepresented in the Aruba cohort. And then we note that their result indicated this higher rate of death and stroke over what was a really very short follow-up, given that what we've discussed about the natural history is an annual risk that bears out over 20 years or 30 years. So this idea of looking at a very short follow-up and looking at an outcome which included a definition for stroke, which I think most of us as surgeons or interventionalists doesn't really comport with clinical management. And that definition was any new focal deficit, seizure, or even headache that was associated with an imaging finding of hemorrhage or infarction. So a very broad definition of stroke. And in that context, and in this short of a follow-up, this design was already set up to have intervention fail, essentially. And sure enough, it did. And if you break out the Spetzler-Martin grades, the Spetzler-Martin grade 1s actually did do better from intervention because their risk of all kinds of complications is so low. But I'll point out that compared to what all the other studies that have broken down 1 and 2 Spetzler-Martin grade AVMs, the grade 2 AVMs had an over 30% risk of this outcome, which is so much higher than has been reported in other series, albeit often retrospective series. So just something about these numbers doesn't comport with the general literature about what risk should be in that cohort, especially if they've been treated surgically. Now, as we'll talk about, not all of these were treated surgically by any means. There was difficulty in enrollment in this particular trial. And in the US in particular, as I mentioned, there were concerns about the study design and a lack of equipoise to include patients into the study. And so I think there is an ongoing concern that there really was a recruitment bias into Aruba, meaning that out of 727 eligible patients, they really only enrolled a little over a third of that. And almost the same number of patients were treated outside the randomization process. That usually makes us think that clinicians felt that a particular patient would really benefit from intervention. And when they didn't, they said, well, let's just enroll you in the trial. So that already creates a dichotomy in generalizability of those results. And it's interesting to look at the couple of the quote unquote top enrollers from the US, Columbia and UCSF, into that study. During the same time frame that they enrolled these 6 and 4 patients, they treated tenfold or more higher unruptured AVMs. This was in personal communication with them. Now, all of these may not have been Aruba eligible, but nonetheless, that is a markedly higher number of patients that suggests there's some recruitment bias going on. And if it's going on at this center, it's likely to be going on at the other centers as well. Other things to note, that this was not really a standardized protocol for intervention that was set out in this trial. That's despite the fact that you really could argue there are standardized, simple classifications like the Spessler-Martin, like the Spessler-Ponti, like the other grading systems that could help guide what management you should do for a given AVM. And furthermore, there was no credentialing of any of the centers other than they managed more than 10 AVMs a year. So no setting a bar for what their outcomes were like before that center could necessarily be part of the study. And ultimately, what you look at is at least comparing what was done in Aruba for treatment compared to US practice at the time. It seemed very disparate. And particularly if you look at the strategies for intervention that were used in that trial, there was about a third of patients treated with embolization alone in an era where that was still very uncommon, and I would argue is still by far the minority of treatment that's offered. And at the same time, surgery, which is a mainstay of intervention in the US, was very minimally used in Aruba, setting up a concern that the type of intervention used played a hand in the outcomes that we're seeing. Since Aruba was published, actually very recently, there was an analysis of those 30 patients who were randomized to intervention being EMBO in Aruba. And they had a remarkably high rate. Half of them had stroke endpoints. So certainly that overprevalence of embolization seems to have driven the intervention arm to have had high event rates. And interestingly, and not surprisingly, patients who were higher Spessler-Martin grade tended to be the ones who had strokes in the context of embolization alone. Now, to be fair, even though there was this high stroke rate, major disability was relatively infrequent. And again, this speaks to the definition of stroke in Aruba, meaning that it's probably overly broad and not all the events truly result in a permanent or functional deficit over time. And importantly, we still don't know from Aruba what obliteration rates were actually achieved, how successful these interventions were. So ultimately, what I would pose is that Aruba had a number of failings in its implementation. It didn't really account for this concern about recruitment bias. There was no parallel registry. They thought about it, but never achieved it. They didn't have any credentialing criteria, as many other trials have had. They lacked criteria for what intervention should be done, and therefore you ended up with endovascular treatment as a sole therapy, and then with very high complication rates. And the length of follow-up really precluded disease-relevant outcome assessment, because this is not a disease that's going to show the benefit of intervention in a short time frame. I think the other major failing was conceptual. The idea of lumping AVMs as one disease, it's a very heterogeneous disease. It's not like carotid stenosis or even carotid occlusion or even intracranial stenosis, where the disease and the interventions are fairly uniform. Both the disease and the modalities of intervention are very heterogeneous. So lumping all these together remains a major challenge in performing a trial that is generalizable. And that brings us to the idea that really Aruba didn't help us determine which patient to treat, if we should treat them, and what modality to use. Really, all it did do was confirm the natural history of about a 2% per year hemorrhage risk. And with all of that, what does the Cochrane review from 2019 says? Well, that's the only trial they have. So what they note is this trial showed superiority. And they suggest more randomized trials are needed. I would propose this is not a disease that's very well amenable to randomized controlled trials. Registries may be more suitable. And in fact, the only ongoing trials, at least on clinicaltrials.gov, are TOBAS, which is a trial based out of Canada. Tim Darceau had, I just emailed with him, and he said there's over 800 patients enrolled in that. That's a randomized trial, but with a registry option. And not surprisingly, what he mentioned is the majority of the enrollees are actually in the registry. So that's an ongoing study that studied results to be seen. And again, not surprisingly to me at least, the majority appear to be in the registry arm rather than the randomized arm. And the other trial that the same group is running is an embolization transarterial versus transvenous trial. And you'll see, of course, that has a much lower number of enrollees. Also not surprising, given that the criteria for who would be suitable for that would probably be very limited. So I don't think randomized trials are going to be the answer for us in this condition in the future. What's interesting is the slew of papers that came out after Aruba, nicely summarized in a paper from Judy Wang's group, showing that basically the event rates from many, many centers are far lower than what was seen, this 30% that was seen in Aruba. Again, these are all retrospective studies, so it's hard to refute prospective data with retrospective data, but it gives us a sense that even in Aruba-eligible patients, the results from Aruba didn't seem to apply to most people's practical experiences. And ultimately, what the AHA scientific statement as of 2017 says is that we should be weighing risks and benefits carefully, not just outright not offering treatment. And similarly, the European consensus statement goes further to say there's sufficient indication to treat grade 1 and 2 AVMs. And the interdisciplinary discussion and complete eradication are key features. So I would say, just in the last couple of minutes, I want to say that from my own and our institutional approach to an unruptured AVM, really we think it's important to have the angiographic features defined to assess risk, to consider all the relevant factors pro and con proceeding with an intervention, and then to treat if that balance of estimate is less than the best estimate of the lifetime risk of the AVM, and to do a treatment that is a complete obliteration. So what does that entail for us? Well, it entails a workup with an angiogram, an MRI, functional MR, DTI if necessary, QMR, which is a way to measure flow. We discuss all our cases at Interdisciplinary Neurovascular Conference. Here'd be the kind of information we'd be seeking. This is our QMR that measures the flow in the vessel, shows us how much flow there is. Based on that, we're going to decide whether to observe or to offer treatment for cure. And rarely do we do palliative treatment, very, very rarely. So this kind of AVM is going to be observed, possibly palliative treatment for any progressive symptoms. This kind of AVM will be observed, similarly, grade 4. This kind of AVM will be operated. And in these Smith-Martin grade 1 and 2, surgery is our main bias. We'll often consider adjunctive embo to reduce blood flow and blood loss. And our approach to that is based on blood flow, feeder accessibility, and really a strategy that focuses on feeder more than nidal embo. And we've looked at quantitating blood flow after embolization, and that strategy we found to be very helpful in actually monitoring the efficacy of our adjunctive embolization sessions. And based on that, proceeding with surgery. So here's a case of an AVM with deep venous drainage, unruptured, high flow, 500 cc's of 400 cc excess in that AVM. and we can measure the venous flow as well. And over a number of embolization sessions that are targeted to flow, we can reduce the flow in that AVM sequentially to almost, not quite, a normal range. And the angio doesn't look all that different because we're not targeting the nidus, we're targeting the flow. And with that resection, the flow then normalizes both in the artery and the vein. And similarly, with this kind of more eloquent region AVM, just anterior to motor strip, again, the embo is really trying to avoid the nidus to keep the nidus soft for surgery. So there's glue really in the feeders, deeper feeders. And then at surgery, what you can see is the nidus then remains very soft. Here's taking a few additional feeders surgically. Everything that's been embolized allows the nidus to stay very soft. You can see that the nidus is being retracted very easily there because there's not a lot of embolisate in there. Very low turgor in both the nidus and the draining vein. Really, the nidus can be manipulated easily. All the retraction can be on the nidus, and it can be peeled away from the brain surface and really just compressed, becomes completely compressible. This is kind of a technique first described by Hashimoto, the idea of taking all the feeders early on, using embolization as just one way to do that, even preoperatively, and then to finish taking the feeders surgically. And here just showing how compressible the nidus and the venous varix is because the flow has been reduced by that strategy. So postoperatively then, again, the flow has normalized. So I would say just our take-home points, I know Jean will be talking about the how he does it, but for us, the way we do it is that workup, a bias towards surgery, this idea of adjunctive embo targeted to flow and feeders, not the nidus, and really rarely therapeutic embo. And again, I think what Aruba showed there too is embolization alone can be somewhat high risk compared to some of these other modalities. So sorry for going a little over time. Thank you very much for your attention.
Thank you, Sepi, very much. As predicted and as expected, a spectacular and very cogent rendition of this complex, but you put lots of good sense into it, and I'm sure the audience enjoyed the summary of all that. And we'll come to questions at the end. So I'd like to invite Jean to share his screen and share with us his pearls on AVM surgery. And make sure you're not muted, Jean.
Yes, you hear me?
Yes, perfect, thank you.
Good evening, everyone. Good evening here in Brazil, in São Paulo right now. First of all, I'd like to say that I really appreciate your introduction words. Thank you very much. It's a great honor to be part of this project of the University of Miami, especially our good friend, Professor Jacques Morcos. Thank you very much for this kind invitation. After this brilliant presentation of Dr. Sepi Amin-Hanjani, it was great to hear all those data from you. It's going to be easier for me to talk about the best part of the treatment of the AVM, which is the surgical treatment. For us neurosurgeons, this is one of the most pleasant surgery that we can face. Every one of you knows very much the pathophysiology of this disease. When you don't have a capillary formation, it's the reason why you have the explanation for the whole presentation, clinical presentation of this kind of lesion. So the connections directly from arteries and veins is the reason why most of the patients has some hemorrhage, seizures, and progressive neurological deficit. So this is the most common clinical presentation. Natural history I'm going to skip because it was brilliantly covered. Of course, from the data presented of Professor Amin-Hanjani, you recognize that the natural history of brain AVM is not so good. It's not good when you have 23% of this series presented by Ondra. This is the longest follow-up in the natural history of brain AVM. So if you follow a patient in a long term with a brain AVM, this patient is gonna have some kind of bleeding during this follow-up. So it's the natural history is not good. Spetzler-Martin classification, it's a landmark in this, in the treatment and the decision-making process of brain AVMs. Of course, there are so many classification systems before Spetzler-Martin and after that. The group from BNI updated this classification and simplify it, putting the grade 1 and grade 2 into the class A, the grade 3 into the class B, and the grade 4 and 5 into the class C. Also, they make some recommendations for class A as a single management with microsurgical resection. For those class B, they recommended multimodality treatment with preoperative embolization followed by surgery, and also for the class C, for most of the patients, no treatment. But of course, it's a general recommendation. So the best way to analyze it is to analyze patient by patient, because the patients have different clinical presentations, the patient has different angio-architectural features in those AVMs. So there are some exceptions for class C that you should consider treatment, which include recurrent hemorrhage, progressive and neurological deficit, the still related symptoms, and things like that. Sepi has already talked about the doubt that we have when you face the patient with a ruptured AVM, if you go to the conservative or intervention. I'm going to skip that, but I'd like to remember you that the great majority of the patients included in the Aruba trial were patients with low-grade AVMs. So if they operated at those patients, I bet with any one of you that the results could be completely different. Because when you see the interventional therapy arm, you will see that among 114 cases, only 5 patients were referred to the neurosurgery. So the bad results of the Aruba trial is because of the bad indication. So I think the good data that Aruba trial brought to us is that we are not treating the patients well. We have to change our management all around the world, because this data is not from the patients from Aruba trial. Everywhere you go, you see patients referring with low-grade AVMs for embolization or radiosurgery as a single treatment. So we have seen from the numbers presented by Sepi that this is not the best way to treat it. So we have to change our way to treat it. The Michael Morgan group have shown that morbidity and mortality from hemorrhages is not good for the patient at any time of the treatment. So this is, it's corroborating with the natural history. I'm going to skip that because it's all right. Based on this data, I believe that for most of these patients, we should consider some kind of intervention. And every time you consider intervention, the microsurgery should be in the core, because this is the best way to give a chance of cure for the patient. To cure a patient using only embolization radiosurgery, the risk is very high. So you should consider all the 3 modalities. I'm going to pass through some basic surgical principle, but the craniotomy should be large to expose the whole surface of the normal brain, especially when you have the motor strip, like in this case, close to the nidus of the AVM. The subarachnoid dissections to achieve the proximal control, in this case, AVM and the Sylvian fissure. So we should start dissecting the Sylvian fissure, recognizing the proximal control and the MCA branch, and then we go to the nidus to dissect the nidus. So it's another basic principle. Before we start to manipulate the nidus, it's very important to recognize the main drainage vein, because this is the vessel which we have to preserve until the end of the surgery. So we have to take care of this vessel. And usually the part of the nidus is under those veins, so we should be careful when dissecting this. ICG may help us in that recognition. And also the knowing anatomy, especially regarding to the deep venous system, it's very important, because this is a risk factor when you have this, and not only for the bleeding, but the surgery it's a little bit more complex. This is a picture from the 7 AVMs book, from Lawton's book. This tell us about the feeding arteries. There are different kinds of arteries that we should recognize during the surgery. Also the PL dissection, circumferential dissection, deep perforated supply. All those basic principles we're gonna try to cover, present some cases to you. And also when the deepest part of the AVM is inside some ventricular cavity, it's the bleeding or the feeding arteries are coming from the choroidal plexus and also the choroidal arteries. So I'd like to share with you some cases that illustrates the way we deal with this kind of lesions. This is a female, 23 years old, presented with seizures and ruptured AVM, a small one located on the supramarginal gyrus, feeders coming from a MCA, superficial drainage, stealing from contralateral and also stealing from the posterior circulation. And look at what happened with the nidus when you occlude the main drainage vein before you occlude all feeders. You see the enlargement of the nidus. So that's what happened when you embolize the AVM, the vein, before you occlude all feeders. That's why the risk of bleeding it's very high. After you occlude both MCA branches that are feeding these AVMs, so now you can occlude safely the main drainage vein. So this is a basics from the surgery of AVM, but it's very, very important to try to recognize it. You only to occlude the main drainage vein after all feeders are occluded. In our daily practice, the postoperative angiography, it's mandatory to make sure that the patients are cured or not if you have some residual nidus. This is a very common patient that come to us, a female, 20 years old, under headache, moral depth after bleeding inside the ventricle, as you can see here in the CT. And the patient was referred to another department where they recommended some embolization, as you can see here. So this is a very common case. The patients go first to angiography, then embolizations, and then after 1, 2, or 3 embolizations, they go to surgery, or after some kind of bleeding, so they are referred to surgery. I believe that most of you have faced some case like this. You see here a small branches come from the ACA feeding the nidus, the main drainage vein going to the deepest venous circulation. This AVM is right here in the corpus callosum going to the ventricle. This is the angiograph. This is a picture from Houghton's collection showing the approach that we perform, the interhemispheric approach. Here is in the cadaver. It's very, very similar as we face in the surgery interhemispheric approach, dissection from subarachnoid patient. Jacques, let me know if the videos are running well, please.
No, it's okay. It's fairly clear. A little choppy, but it's fairly clear.
Okay. So you can see here the knee of the corpus callosum, the both ACAs, the pericallosal artery. So it's a basics to have a proximal control. And then we start to dissect the nidus. As you can see here, some yellowish aspect showing, confirming the previous bleeding. Look at the corpus callosum right here. And then we start to dissect the nidus. I'm gonna speed my video in order to save time. And then we enter in the ventricle, look at this vessel that is not part of the nidus. So this is very important to try to recognize the vessels that are part of the nidus, the vessels are not going to the nidus. As you can see here, this is the medial border of the nidus right here, but this vein is not part of the nidus. So we have to preserve it. And as you can see here, and still dissecting the nidus. This is the posterior aspect. Here you can see the falx, the posterior aspect of the falx. You see here, this is like a stone because the material of the embolization. So sometimes the embolization makes the dissection harder, and that's why we do not recommend embolization for every case. In addition, the embolization have some risk of bleeding during and after that, so we have to take care with our recommendation. So this is the pre and post operative angiography showing a complete occlusion of this or complete resection. Another case, 32 years old. Now I'd like to highlight the decision made regarding the approach. When we have a lesion like that laying down over the tent, or every time we have a lesion like that, we think about to make a transtentorial approach. You see branches from PCA feeding the nidus. So this lesion is located right here in the medial aspect of medial temporal lobe. I had the privilege to learn from Professor Evandro de Oliveira how to do the supracerebellar transtentorial approach, in which I could publish along with him. It was cover of Journal of Neurosurgery. We became very honored about that. So in this paper, we removed the whole tent, which provides an excellent exposure of the medial temporal lobe. In my patient, in this case, I did different of our publication. Dr. Evandro used to do that in a semi-sitting position. I prefer to do that in a supine position like that. The craniorum should be large in order to expose the bilateral transverse sinus and a little bit of the occipital lobe, because when you open the dura and retract the dura, you have plenty of space to go supracerebellar. The surgery should start with CSF release. You see that after the CSF release, even a supine position, we have plenty of space, plenty of room right here. You see the transverse sinus, and now I'm just cutting some arachnoid bridge. Of course, we have to sacrifice some small venous vessels right here in order to get a better exposure. And then after that, we try to go in the medial aspect up to the free border of the tentor, like you see here. The beauty of this approach is because you go directly to the PCA, and then you don't have to go through the normal brain. So after that, we coagulate the border of the transverse sinus from inside the tentorial aspect. So this is important in order to coagulate and then cut it. as you can see here, and then coagulate a little bit more and go up to the free border of the tentorium in the medial aspect, as you can see here. And then when you open, coagulate the last part, and then you see the whole medial aspect of the temporal lobe, the ambient cistern, and then you go directly to the proximal control and the PCA right here. And after that, you have the anatomic exposure of the branches that are going into the nidus and the branches that are going to the normal brain. So the nidus is located right here. So we are trying to preserve this main branch for PCA, just coagulate the small branches that are going to the nidus. So this is a exercise that we should try to do in those kind of surgeries in order to preserve the normal vascularizations and just sacrifice the branches that are going to the nidus. And then we start to dissect in a circumferential fashion, as every one of you know. And after that, you see that the most anterior part of this nidus is going into the lateral horn or the temporal horn of the lateral ventricle. So I know that when I reach the ventricle, I should be at the end of the most anterior aspect of the AVM. I'm going to skip here. So you see here the last branch. So this is the PCA going to the normal brain. So the last vessel is the main drainage vein, which is right here, going to the deepest venous circulation. So this is the last vessel to be occluded in the surgery. I hope you are seeing the video well. So I'm cutting the vein, and you see that we have with this approach a very good room going directly to the nidus, not going through the normal brain, and then you can remove the nidus as a single piece, as usual. And you see that part of the nidus still open. And then at the end, we go into the temporal horn, as you can see here, the ependymal wall, the choroidal plexus. So we have a clear impression that we remove the whole nidus. So to reconstruct the dura, to reconstruct the craniotomy, the bone, the postoperative angiography, it's very important steps to make sure. You see there, we are showing different low-grade AVMs. Every single case has some different features. This is a large nidus going to the atrium of the ventricle, feeders coming from MCA, feeders come from PCA. And you see right here, after you occlude the MCA branch, which are in the surface of the brain, we go to the deepest part of the AVM. Sometimes this is the toughest part in the surgery. And you see here that we must take care of this deepest part, because this is the highest risk to leave some residual nidus. So this is a main drainage vein, the complex of Labé region. So when we have a nidus like this, it's easier to dissect when we have a diffuse nidus, so the surgery is a little bit more difficult. When we open the ventricle cavity, we prefer to leave some EVD catheter in order to have control in the postoperative time if the patient has some bleeding, or even to control the ICP. Postoperative show complete occlusion. I have showed this case in some other webinars. I have the privilege to operate this case during the course in Russia, Siberia, the the department of Professor Sofia Nova in a course along with Professor Luis Borba. They have a beautiful facility over there with intraoperative CT. So we start the surgery doing an intraoperative angio CT. It's a 15 seconds to get the image directly to the image guidance system. So this facility makes the surgery very, very interesting. So in this case, this intraoperative imaging showing that sometimes the preoperative embolization make different compartments in this AVM. The embolized compartment is the biggest part of the nidus is still open. So we did interhemispheric approach. Sometimes it's preferable to sacrifice the dura when it's very attached in order to save the veins when you perform this kind of approach. Interhemispheric approach combined with intrasucal approach, we remove the embolized part through interhemispheric approach and remove the live nidus through the intersucal approach, like you see here after the dissection of the nidus. But the vein is still live, as you can see here. So it's very, very important to try to save those. And then because we have that facility, we perform another angio CT that was consistent with a complete removal of the AVM. And the day after, we performed the post-operative angiography that confirmed complete removal. Sepi has already showed this beautiful systematic review that shows that morbidity mortality of the microsurgeon regarding low-grade AVMs is very low when you compare with endovascular and radiosurgery. So also the cure rate for microsurgery, it's almost 100% against only 30% for endovascular, is 75% for radiosurgery. So there is no reason to not offer microsurgery as the first option when you face a patient with a low-grade brain arteriovenous malformations. Going through class B, here is the different situation. Most of these AVMs, we prefer to perform a preoperative embolization, especially when you have a large nidus with aneurysms inside the nidus, as you can see in this case. Stratigraphy may help us to see where the tracts are displaced from the nidus. In this case, we had some intranidus aneurysms, the deepest venous drainage, contralateral flow. So for this patient, we indicated the preoperative embolization. Of course, when you have this, the impression during the surgery is that the surgery is easier because most of the nidus, the greatest part of the nidus are embolized. The flow is reduced, but we still have some flow coming from the deepest part of those AVM, because unfortunately the endovascular treatment is not go to occlude those small branches coming from the deepest part. Those vessels still open during the surgery. Sometimes it's very tough to stop the bleeding that comes from those. So this is the last vessel to be occluded, the main drainage vein that is going to the superior sagittal sinus right here. This is the frontal basal aspect. So this is the nidus, and this is angiography in the postoperative time. As I told you, there are a lot of patients that come to us after 1, 2, 3, 4. I have a patient with 10 embolizations already, and they come after some bleeding. So they embolize once, twice, and then the patient bleeds, and then they refer to the surgeon. So I don't think this is the best way to treat those patients, but this is a good example of that. 3 embolizations. After the 3rd embolization, the patient had a bleeding. They became almost hemiplegic because the AVM was over the motor strip. As you can see here, the motor tracts were displaced to the posterior aspect of the AVM, branches coming from the ACA and MCA. This is a risk on a single drainage vein going to superior sagittal sinus, so this is a risk factor for bleeding. This is a large craniorum. This is the same example that I have shown before. Look at, this is the part of the AVM that was embolized. I don't believe that it's used for this AVM surgery. So this is a motor strip. We performed the brain mapping before we started. So here is after the dissection of the nidus. So here is the motor strip, and this is the part that was embolized. So this was very hard, like a stone, and it was very stuck into the nidus. So this was the most difficult part to dissect in the surgery, and also the potential evoked monitoring. It's very important to make sure that we are not manipulating too much the motor strip. This is the nidus, the pre and post operative. The patient is still presenting with some hemiparetic, but she's improving after some rehabilitation physiotherapy. There are some examples like that, class B, that we try to convince our endovascular team to embolize the deepest part. But in this case, they offer us to occlude here, here, in the middle, but here they don't they believe that they couldn't catheterize this small lenticular striated vessel to go up to here or even through the nidus. So we decided not to embolize the part that wasn't surface, because we believe that the very beginning part of the surgery could control the proximal vessels from MCA, ACA, large craniotomy. Look at how the vessels could make an impression in the inner table of the bone, showing the congenital aspect of this kind of lesion. So we should take care of the superficial vessels since we open the dura, because sometimes the dura is attached in the superficial vessel. Look at here, I'm just putting a clip in the ACA just before it entered in nidus. So this is the main drainage vein, and these are the both branches come from the MCA. So at the very beginning of the surgery, I have the control of the MCA, ACA. The only part that I don't have control is the deepest part of the AVM. So that was very, very useful, that if they could embolize it. So I'm going to skip this in order to save time for a couple of cases. And then the postoperative angiography showing complete occlusion. And this is the patient the day of discharge, 10 days after surgery. Finally, the last part of this lecture is showing an example of high-grade brain arteriovenous malformation. If you look at the literature, of course, the results for those kind of AVMs is not so good as we have for low grades and also for class B. This example, when we indicated surgery for class C, a female, 32 years old, seizures, progressive left hemiparesis. The patient was getting worse. She had a previous surgery for hematoma evacuation. She had a previous radial surgery 5 years before. And look at this. That patient go to the public health system hospital with a huge hematoma, and of course they face the AVM. They entered just to operate the hematoma, and they face AVM. They put a lot of metallic clips in order to stop the bleeding, left the AVM there, and said to the patient that they couldn't do anything more. So you see here that the part of the nidus is inside of the ventricle, and they do not refer her to the endovascular and refer only to the radial surgery. And as you can see here, they still have a large nidus even after radiosurgery, confirming that radiosurgery is not a good strategy when you have a large nidus like this. And look at that part of the feeding is coming from the external meningeal arteries. And the first basically was enlarge the craniotomy. So the first thing that I did in a reoperation was enlarge the craniotomy. Because it was a reoperation, you can see here that the dura, it's very, very attached to the surface of the brain. So we should take care when you try to dissect it, because sometimes we can damage the main drainage vein, the very beginning of the surgery. So this is not good. So this is the main drainage vein right here. So this is the vessel that I like to recognize at the very early part of the surgery. And then after that, I try to use this vein as a landmark, working in the front of the main drainage vein. Right here is the superior sagittal sinus, right here. So it's draining to the superior sagittal sinus. So we start to dissect in the superficial aspect and then go deeper and deeper. In this case, this patient had bleeding. This patient had some radiation from the stereotactic radiosurgery. So we have a good dissection plan, especially in the deepest part where she had some blood. So we go superficial and then go deeper and deeper up to this deepest part, that some branches coming from the choroidal artery, as you see here. Part of the nidus was going into the atrium of the ventricle, as you can see here, the ependymal wall, and you see part of the nidus inside the ventricle, and then some branches coming from the choroidal and deep vessels. So you see here some plan for dissection. This is my last case, Jacques. I'm just finished.
Perfect. Thank you.
So you see deep vessels coming from the ependyma, coming from the. Here you see the choroidal plexus, and a small branching that was coming from the choroidal plexus to the deepest part of the nidus. And then the last vessel, the main drainage vein. So we could isolate all vessels and dissect and remove the nidus, as you can see right here. So even class C with multiple hemorrhages and progressive neurological deaths, you should include surgery in a decision-making process to treat those patients. So this is the post-op. Look at the size of this nidus, more than 6 centimeters, even after so many coagulations. So this is not a good case for radiosurgery. We published this in Neurosurgical Focus, so you can find this video in the web. Sepi has shown also this beautiful paper. In this paper, they consider all papers about treatment of brain AVMs, showing that the case fatality, there is no difference between microsurgery, stereotactic radiosurgery, and embolization, 0.5 and 0.9. So the risk of hemorrhage after microsurgery was 0.18, and after stereotactic radiosurgery was 10 times higher, more than microsurgery, and also embolization, the risk is 10 times more than microsurgery. Complications 7, 5, 6, no difference between the three modalities, but the chance of cure 96% for microsurgery against only 38 in only 13% for radiosurgery embolization, respectively. it makes us to conclude that microsurgery should be in the core of the treatment of the brain AVMs. This is the Santa Casa de São Paulo School of Medicine in the old times. So this is the Santa Casa nowadays. So any one of you is most welcome to visit us anytime. I'm sure that our chairman, Professor Veiga, will be very happy to have any one of you. And this is a Camargo Cancer Center. This is the largest cancer center in the private cancer center in this country. So you are most welcome to visit us anytime. So I really appreciate, I'm delighted with this invitation. Thank you very much for your attention.
Thank you, Jean, very much for this surgical tour de force, showing us all these AVMs and the technical aspects of it.
I'm not hearing you, Jacques.
I am not mute. You guys hear me?
Yes, we do.
Yeah,
Yes,
you're
we
not
do.
here. Yeah, they hear me. Maybe. Yeah.
Yeah. Okay.
Great. Thank you. Can you stop? If you can stop sharing, perfect. And thank you. I was saying that wonderful presentation. I'm going to invite Dr. Jafar to share his screen with us and ask our speakers and the other panelists, perhaps, what they would do about the case he may have for us.
Thank you, Jacques, and thank you for arranging this marvelous series. I hope you hear me well.
I hear you, yes. Your screen is not on, it's like a funny presentation mode. Is it? Yeah, we see it. Yes. Yeah.
Okay, the thing is that what I'd like, I don't know why it's doing that, but maybe I'm sharing my screen. We had two excellent presentations. They really were very good. And I just wanted to make a couple of comments. Having been a neurosurgeon for 35 years and operated on more than 500 AVMs, I pretty much agree with most what people have said, or the majority of it. I have noticed that neurosurgeons are getting lazy a little bit, in that they prefer to, it's much easier to do radiosurgery, stereotactic radiosurgery, than to spend a couple of hours doing an AVM, which is one of the things that has caused the numbers, especially, I don't know where you are, but at NYU, we've had a drop in the number of surgical cases. The other thing I want to mention is that it's very important to know your endovascular team. I strongly believe in endovascular embolization preoperatively, and I have not had problems with AVMs being hard or not being able to take them out. On the other hand, you are absolutely right. Both presenters mentioned that the deep perforators are usually not amenable to endovascular embolization. And the treatment for those is not very difficult. You just take a big sucker and you follow it. It's a scary feeling in the beginning, but unless you go to the source, and usually once you get into the ventricle, you can easily get those endovascular, those deep perforators. So this is a young lady who is 39 years old. In 2011 or 12, she had a subarachnoid hemorrhage, or an intraventricular sort of cerebellar hemorrhage. And I wanted to get the opinion of the people participating over this, because it's a difficult case. I don't believe that surgery is the optimal treatment for her. As you see, she's got a lesion sitting here and next to the aqueduct. I'm not aware why is this presenting like this. I'm sharing it, but.
We can see it, Jafar. The third column of images came up.
Yeah, it's going slowly, but you can see it's the deep AVM. There's a big vein going into the aqueduct pretty much, and that was giving her a little bit of hydrocephalus. She had required a ventriculostomy. And subsequent to that, we saw her in 2016. And in 2016, she presented with some dysarthria. And other than that, was doing quite well. We performed an angiogram, and when I say I'm talking about our endovascular team, including Dr. Nelson and Eitan Raz, and Dr. Konzioka from stereotactic radiosurgery at our institution. And when you look at this AVM, you can see that this is a complex AVM, deep. It's not very big, and it's draining into the, primarily into the precentral cerebellar vein and into the superior sagittal, into the superior petrosal vein over here. So after an extensive discussion, really, this was the AVM. Targeting it was a problem, was difficult. And we went ahead and radiated her with 18 gray in 2016. And this is sort of a depiction of the venous drainage of this AVM. I don't know if you can see it well. And finally, she had a little bit of post-operative radionecrosis and double vision, which was treated conservatively and disappeared. Presently, in 2020, she has minimal dysarthria when she speaks, and the AVM is a little bit smaller, but not much. And the question is, what to do for this AVM? You can see this vessel going right through the brainstem. That's a vein. And it's a small AVM with a small enhancing lesion that's in the bed of the AVM. And I'm wondering whether there is anybody that has anything else to offer, because this AVM has not been cured in a 39-year-old patient. So anybody wants to volunteer any new ideas that we can do for this? We are very reluctant to re-radiate her again because of the higher morbidity.
Sepi, you want to tackle this, and then Jean?
Yeah, I mean, I don't think I have any good answers here. I think, thankfully, she hasn't bled, it sounds like, since you've done the treatment, even though the AVM is still present. And one has to presume that if it's not obliterated, its natural history will retain, meaning that she is at some ongoing risk of hemorrhage over time. It's interesting. It almost seems like there's that she has a DVA as part of the drainage pattern. I mean, there's more of a venous component here than the AVM is itself. But as for the AVM itself, I agree. I think a surgical approach risks a deficit for her in that location. You know, it's really within the brainstem. The radiation sounds like it's been 4 years. I mean, certainly we've considered re-irradiating, but in the context of her having had radiation-related symptoms already, that seems very unattractive. And there doesn't, based on the angiogram, appear to be, at least from that quick estimation, something that could be offered from a curative aspect from embolization. So sometimes I think the best thing is to do nothing. And I think that's what I would lean towards with this.
Jean, is there a surgical option of this AVM similar to some complex spinal cord AVMs that I remember Spetzler talking about early on, that you don't actually need to remove it as long as you kind of cut some of the blood supply entering it? What are your thoughts?
This is a terrible example. That's a tough AVM. So I would recommend, if I had to recommend something, because the conservative management, it should be considered, because the patient it's in a good clinical conditions right now. And as Sepi has said, the surgical option here, it's a right risk of some postoperative deficit. I would try to talk with the endovascular team and the radiosurgery team in order to find some combinations between the two modalities for this. I know that it was already radiated, but I would consider a new radiation if they can do that. I would say that I would observe, because she had only one bleeding. So after the first radiosurgery, sometimes those vessels became more resistant. So sometimes it worked and there's no bleeding, but the natural history is not so good.
Yes, I mean, that's what we decided to so far. But she's young, one hemorrhage, and doing well. That's the problem. She has practically no deficit, no double vision, nothing. But we received this, we came to the same conclusion that you are alluding to.
Jafar, I'm surprised 18 gray to the 50% isodose inside, I assume inside the brain stem. That's pretty hefty dose. That was courageous. Yeah.
It was, you know, Dr. Konziolka is a courageous guy.
Yeah, I know he is.
And, you know, to his credit, the patient is doing quite well. Unfortunately, the AVM is really not a very compact AVM, and it has not responded very well to radiosurgery.
And the other thing is, as we all know, with radiosurgery, and well, we've got Carolina here, my co-director, also online. We can, you know, did a fellowship with Doug, well, and residency with you. The question, they can fail either because the targeting is poor, which I doubt very much Doug would have done that, or of the radiobiological resistance. Do you know if it was targeted with a mixture of both MRI and an angiogram? Or
yes, she was. The targeting was really perfect, and as you can see where the targeting was on the post-op result and where the necrosis. It was perfect targeting.
Yeah.
The question is, I don't think everybody's reluctant to give her any more radiation.
Dr. Nathal, I know you're muted. Do you have an opinion different from the speakers on this case? Any advice, Dr. Jafar?
No, I think that at first observation is a good protocol. And if the bleed repeats, then we have to act. And maybe radiosurgery could be a second option after speaking with the radiosurgery department, because she received a previous dose, but at first observation.
Yeah, you know, Jafar, if she bleeds again, you know, I was mentioning earlier, I wouldn't be against going supracerebellar, you know, infratentorial, not to excise it, but to, you know, just ligate, coagulate, and cut the feeders without removing it. It works in the spinal cord. You know, the concept. I don't know why it works, but it works. So
no, I agree with you totally. We're waiting. If she does then bleed again, then we will have more impetus to go in directly at surgery. I think at that point she probably will have some deficits that would justify us going in and doing something about it. It's very hard to re-embolize her. The vessels are very small.
Anybody else has any input on this? Otherwise, I'll ask Dr. Nathal to present his case after Jafar. Yeah, stop sharing. Thank you.
I would just add that, you know, so you radiated her, right? So you have that radiobiologic response that is not necessarily done at a fixed point in time. So that would support giving it more time, so to speak, because there's still a process at work that might be in your favor.
She's 4 years out, so I don't know. Hopefully.
Thank you, Edgar. Welcome, and please, you know, share your case with us.
Thank you very much. Good afternoon for all the participants. And I want to introduce some controversies in the treatment of the AVMs. At first, I have to say that I belong to a reference center, the main institution about neurological disease in Mexico. And we have a AVMs committee. Every case is discussed in the AVMs committee, and this is integrated by members of the endovascular radiosurgery and vascular neurosurgery departments. We have one or two sessions each month, especially related to AVM cases. Every case is presented, and any case can be treated if has not been authorized by the committee. So the committee is formed by the Dr. Sergio Moreno from radiosurgery department, Dr. Marcos Cintino of endovascular therapy, and myself as representative of the vascular neurosurgery. I want to present one common case, but I have some particular issue that I want to present you for discussion. This is a 48-year-old female starting with episodes of dysphagia, headache, and one isolated seizure as initial symptom 10 years ago. An MRI study showed a left sylvian AVM with very rapid flow. She received fractionated radiotherapy because the AVM was more than 3 centimeters in size. So after the radiotherapy, she was maintained in follow-up. And in the last MRI and angiography, the AVM was still present. And I want to show you these studies. This is the MRI, sequential MRI. The first is 1 year after fractionated radiotherapy. The second is 4 years after. And the last is 10 years after. You can see that the AVM has some reduction in size, but is still present. But this is not the reason because the patient was presented to the committee. There was additional finding. This is the angiography that shows the persistence of the AVM with a main drainage vein and a second to the trolar system. But there were additional findings. Look, one ACOM aneurysm, one anterior choroidal artery aneurysm, and on the opposite side, there were 2 de novo AVMs that were not present at the beginning of the treatment 10 years before. This is the arrow shows the findings and the questions that I can do about this case. Radiotherapy is or was a valid alternative being a rapid flow AVM. The second is what to do about the aneurysms. If they should be observed, treated by endovascular or microsurgery. And what about the de novo AVMs? They should be maintained on observation, radiosurgery, or microsurgery. I want to ask to the panelists, I invite to answer these questions, and after I will show you what we did with this AVM.
Great case. Okay, Jean, you take this one first, and keep this slide on, Edgar, so they can see the questions.
Okay, I don't think the radiotherapy it's a good option in large nidus AVMs like this. For that case, I would recommend surgery, sometimes with preoperative embolization and followed by surgery. Because the aneurysm, the AVM is inside of the sylvian fissure, as I could see from the pictures. So you could perform a pterional craniotomy and go to the ACOM, clip the ACOM and go to the anterior choroidal segment of the carotid and put the clip and then go to MCA to have a proximal control of the feeding. So I would try to treat all the lesions with surgery in this side. Of course, there are some reports that when you occlude the nidus, the aneurysm disappear if they were considered as a flow related aneurysm. And about the contralateral de novo AVMs, they are small nidus AVM, so you could consider some radiosurgery or even observation for that, but I could not see if they are superficial or if they are deep. I think they are deep, right?
Right.
Yeah. So for the deep small AVM, I strongly consider the radiosurgery.
Sepi, do any different opinion?
So no, I would say I very largely agree with that. I think I've seen obviously aneurysms that regress with AVM resection, but I would say that has been pretty much entirely in the situation where the aneurysm is on a feeder artery, as opposed to being in the circle of Willis or a more proximal aneurysm. So I do think I wouldn't have any illusions that that ACOM aneurysm would regress. I mean, or be completely obliterated. Whereas I've seen, for example, PCA aneurysms on a PCA feeder that have completely regressed after the AVMs were resected. I think the ACOM would require attention and be treated for that reason. The de novo AVMs make me wonder about HHT in this patient. You know, why has she developed 2 new AVMs? You know, does she have a, you know, does she need a workup for hemorrhagic telangiectasias? Is there some underlying reason she's prone to this? I mean, that's really the situation I've seen multiple AVMs and de novo ones arise is in that genetic predisposition to it. And I would agree, I think radiosurgery for those small ones seems like a reasonable option as opposed to additional surgeries.
Anybody on the panel wants to offer an opinion?
I'm sorry, how old was she and what are her main complaints now?
48 years old now.
And does she have any problems now?
Now, well, she's under seizure control, but continues with some speech problem from time to time.
So she's left hemisphere dominant.
Yeah.
Yeah, I mean, this is a difficult problem. I sort of agree with what was said before, but however, I would not poo-poo stereotactic radiosurgery. We have had a significant number of patients where you stage stereotactic radiosurgery. This concept that if it's more than 3.5 centimeters, therefore you can't treat it with radiosurgery, that is way old-fashioned. You can target different parts of the AVM at different times, and that might be another option that you have for her. If you look at it at the Spetzler-Martin scale, if you want to take this AVM out, you have not an insignificant risk of damaging this patient. I agree with Sepi that the ACOM has to go away. I have in fact seen patients and aneurysms even grow after you resect an AVM. So that's not an issue. I think the ACOM has to go, and I would not poo-poo or totally take out the consideration for another radiosurgical approach, which might be more conservative and less damaging, especially since she has not had a second hemorrhage.
Edgar, why don't you tell us what you did?
Yeah, okay. At first, I will tell you about the contralateral de novo AVMs. This is a rare case because his brother also had an AVM. So there is maybe some genetic problem there. And we have a very few cases of de novo AVMs. We decided to observe the behavior of the AVMs, and if the AVMs become symptomatic, the decision was to treat through radiosurgery. Respecting to the AVM and both aneurysms, what we did was planning one operation to clip both aneurysms and at the same time to resect the AVM, based on the fact that many AVMs after stereotactic radiosurgery fractionated, the vessels becomes less active, and it seems to be that the AVM could be resected more easily. This is the experience of the San Francisco University, Michael Lawton. So we decided to treat. The other thing was the AVM at present was smaller than the original size. So I will show the video. The video has sound, so I will not speak. Excuse me, because it's shortened from the original video, but it will show you very clearly what we did.
Two hyperflow aneurysms at the ACOM and the left internal carotid artery. The AVM has a rapid flow and 3 veins of drainage. In addition, there were identified 2 de novo small AVMs at the right hemisphere. The angiography showed the presence of 1 artery in passage and 1 direct feeder to the AVM, with a wide exposure of all the sylvian fissure. At the beginning, a yellow 560 fluorescein filter was used to identify the superficial vessels of the AVM. The process in a complete fenestration of the ACOM with the aneurysm in high position. After opening the interhemispheric fissure, the dome was dissected. The aneurysm was clipped under temporary clipping of both A1 segments. A 7 mm straight clip was used, and its position was confirmed after releasing the temporary clipping. Then we moved to the internal carotid artery, dissecting the arachnoid tissue around the carotid until we visualize the aneurysm. After dissecting the neck of the aneurysm, we apply a semi-curved clip. The anatomy is again confirmed, is identified and clipped. The distal sylvian fissure is dissected to localize the arteries. A peripheral dissection is completed. The nidus is isolated as well as the main vein of drainage. The remaining feeders are exposed with the yellow filter and fluorescein. At the bottom of the sylvian fissure, we found an artery going into the nidus, are coagulated and divided. This coagulation is made progressively until the artery is separated from the nidus. Finally, the connection of the nidus with the main vein of drainage is coagulated and divided. The vein becomes dark and soft. The nidus is now free and is taken out. A final examination with the yellow filter is made to confirm the absence of any residual vessels at the surgical field. This is the final view of the surgical field and the nidus. The post-operative angio-CT shows the clipped aneurysms and the total excision of the AVM.
Okay, in conclusion, the aneurysms were clipped before removing the AVM. The AVM was totally resected, as you see, and de novo AVMs will be maintained under surveillance for in the future, seeing how is the behavior of this rare case of de novo AVMs. You can see the total video for the residents. I have a channel especially designed for residents with the most demonstrative vascular cases. You can find YouTube this channel and see the complete video and other AVMs videos. Thank you very much, Jacques.
Thank you, Edgar. That was terrific. Wonderful discussion. Great example for the session. Congratulations. Very nice result. Clemens, may I ask? Oh, could you unshare? Yeah, stop sharing, and then I invite Clemens Schirmer to join us and share the case he may have for us.
So thanks, Jacques, and all the co-directors for putting this together. Can you see my screen now?
Yes, you may want to go on presentation mode. You're in navigation
Okay.
mode.
So,
Yeah.
I don't want to necessarily belabor showing another case, although, I think I do want to get some advice. This is maybe not quite as, unusual or special as the cases that were shown before. This is a fairly young person who presented with, essentially was described as several hours of lethargy. No previous history other than history of bipolar disorder that has been documented since young age. But interestingly enough, this has also been the first time that he underwent cerebral imaging. And he presented with this. There was, so I questioned whether or not there was a bleeding episode with some blood. But we were not sure if this is like, a symptomatic case in that sense. So I want to pose the question, showing some additional pictures here of this AVM and an attempt to capture the dynamic aspect of this. How would the panel treat this? But before you guys get into this, I want to actually ask two additional questions. For one, what is the sense of how should we address the variation between practitioners when it comes to treating AVMs? Obviously, everyone who has spoken here and has shown his or her cases is a master practitioner of the field. We all have published on AVMs. We have driven the field forward, but obviously not every patient has the ability or the opportunity to actually get into your practice and be treated by you. There's more than 5 or 6 people in the world who treat AVMs, and I think the variation between practitioners is a big problem. And how do we, I guess, go forward and rein that in? How do we make something positive out of that? And then the other question I had is, how long do you follow AVMs up over time? When you're, especially the ones where you think that you cured them, do you discharge them from your practice? How long do you follow these patients up? Is that a lifelong follow-up, or what is the sort of consensus here?
So, good questions. So Sepi, should AVMs be treated only in tertiary referral centers, or should our grade 1 and 2 AVMs treatable by a general cranial neurosurgeon?
So, I mean, this is, of course, going to sound, and maybe is to some respects, self-serving, but I would argue that it's a rare condition, as I said, and it's a low volume condition in general. And thus, I think it is the perfect example of a condition that's relatively rare and yet complex, and therefore perfect for centralization. Meaning, I think this is the kind of case that should be sent to centers that are managing these routinely in an interdisciplinary fashion, just in the way that cases that have been presented and presenters have noted. The idea of discussing each of these cases, Edgar mentioned that no AVM proceeds unless the whole committee agrees upon it. I think that concept is incredibly important, not just the idea that it's done by high volume individuals, but it's done with the group setting of high volume individuals and people with different specialty expertises. So again, I mean, that may be self-serving to say that, but I think it's also patient serving, because I think it is, as Clemens is, I think, getting at, is that there's complexity of the disease. Even a grade 1 or a grade 2 AVM, there's decisions to be made about what modality to apply, the relative risks and benefits of that. And so that would be at least my case, that as with many conditions where volume outcome matters, even more so for complex and rare conditions. And I think that really meets that definition.
Jean, how do you want to handle the AVM, the case itself, or you want to answer Clemens' first questions? Or
yes, for this case, that he presented, I would try to embolize the most lateral aspect of the AVM, and then try to make the same approach that I showed, the transtentorial approach. This is a little bit large nidus to go through this approach, but I think still have a room to do that. But I'm
sorry, you mean supracerebellar? Is that what you mean? From below?
From below, supracerebellar transtentorial approach.
Yes.
Yeah, maybe to make a preoperative embolization in the target in the most lateral aspect of the AVM, which is sometimes is the most difficult part when you use this approach.
And you say that just to clarify to the younger people who are listening, and there are many of them. You're saying that because you think that's less traumatic to the temporal lobe, to retracting it to get to the lesion?
There are the options to approach this any lesion located on the same space. You have to go through the cortex if you want, but it's not a good option. You can go subtemporal, and then you have problems with the vein drainage in the system of Labé. Usually, this is the two options. The other option is go posterior interhemispheric approach, which is also not so good. All those approaches, you have to make any lesion in normal brain to achieve or to reach the nidus. So I think the supracerebellar transtentorial approach leads you direct into the PCA branch and direct to the nidus, so you don't need to cause any damage to the normal brain. So this is a beautiful approach. But try to answer the other questions. I would say that in the ideal world, the best thing for the patients is to be treated by the very, very experimented surgeon in any kind of lesion. But in the real world, especially in my daily practice, if you say that only few groups of neurosurgeons can treat AVMs, all AVM is going to be treated by endovascular and by radiosurgery. So I think we should create a different strategy to try to train young generations of neurosurgeons, at least to treat low-grade AVMs. Otherwise, if the young generations of neurosurgeons don't feel comfortable, don't feel confident to treat this kind of lesions, I have to say that in the future, we have a few neurosurgeons around the world operating this kind of lesions, and the great majority will be treated by radiosurgeon and by endovascular as a single treatment, not as a combined treatment. Unfortunately, this is the reality of our specialty.
Clemens, what else you want to ask them, or what do you want, or have you treated the?
So I haven't treated this yet. I'll tell you next time, I guess, if you invite me back. But I want to ask this other question about how long do people? This is maybe a little bit easier and straightforward to answer. How long do people follow AVMs, especially after successful resection or cures, so to speak, that you may have seen angiographically even?
Jafar, let me pull you into this one. I'll tell you what I do personally while Jafar thinks. So when I remove an AVM, I do an immediate post-op, immediate meaning same admission. If it's cured, of course, there's nothing to do right now. I always do one 3 years later. I don't do anything intervening. I do the same thing with clipped aneurysms. Children, as we all know, I'm not I don't know, none of us is probably a dedicated pediatric neurosurgeon, but children, you'd have to do this a little more frequently because of the recurrence rate. Jafar, how do you follow up a cured AVM in an adult?
I think what you mentioned is right. My philosophy is if a patient is below the age of 25, then I will follow them until they're at least 25, especially if they want to get pregnant. I will get an angiogram at that age. So any teenager up and person until 25, I will follow them. with an angiogram at 25, even if it's cured. All my patients undergo an intraoperative angiogram. I don't wait for the next day. We do angiograms immediately before the head is closed to make sure everything is gone. Now with the Pheno and the Xeno and all these intraoperative rooms, it depends on the patient and how they are. If I feel that I've done an angiogram a couple of years later, like 3 years later or 4 years later, and the patient is cured and he has no other problems, then I let them go. If the patient still has seizures, still has other problems, then I will keep on following them forever, because patients, that kind of patient will depend on you.
Bobby, are you online? Bobby Stark? I'm not sure if he's still here. I was going to okay.
So, Jack, just to mention something about that issue of recurrence and follow-up. So a couple of years back, we actually published a series of delayed recurrences in adults, which is quite rare, as we all know. I mean, much more common in the pediatric. But, you know, we'd had a long-term follow-up on about 80 surgical patients out of the 200 that had been operated during that epoch of time. And of those 80, I think there were 3 or 4 recurrences. And what was very interesting about that, and kind of changed our practice of follow-up, and also to some degree changed our practice of preoperative adjunctive embo, is that all of those cases, the recurrence was in the area of embolized nidus.
Yeah.
Which is why I feel like, you know, embo for cure cases, in my mind, probably need to be followed forever, because I do think there is some, and again, Bobby and others can maybe, you know, counter me on this, but I think there's some phenomenon of recanalization that can happen, or it is that the embolization hides some component of nidus that then, you know, becomes apparent again in the future. So, I mean, it was a small number of recurrences, 3 or 4, but nonetheless, all of them were exactly, we could track back to the location where a component of embolized nidus that presumably, you know, wasn't resected because it wasn't visible post-op angiographically, and at surgery had not been resected with the rest of the filling nidus. And because of that, you know, we're doing longer term follow-up on any patient who has had pre-op embo. So we'll do a 5-year follow-up on them for that reason, as opposed to just one-year follow-up. And as I mentioned in my talk, we've kind of shifted away from nidal embo as a philosophy and shifted to feeder embo, because we're really utilizing it to cut the flow down. And I think, as Jean mentioned, you know, when you have a lot of embolizate in the nidus, it's counterproductive surgically. You really don't want that firm glue impeding your ability to manipulate the nidus. And so those small number of cases really shifted our mind about both our embo strategy and our long-term follow-up strategy for that reason.
And that's not a super small number of cases, right? I mean, that's 5%.
Right, right.
You could argue that's not small.
Yeah, but the UIC group got better technically since then. Now they know how to remove AVM more completely. No, that's important data. Yeah, no, for sure. Bobby Stark, can I pull you into the conversation about recanalization of partially embolized and surgically resected AVM, and maybe talk about the newer trend of endovenous embolization? Do you think it's a dangerous, you know, just give us free thinking on all this.
Yeah, of course. I mean, I think for the patients that we are embolizing before surgery, it's really mostly just to take down deep branches. And I agree with you. I don't like to embolize the nidus. I think it makes the nidus harder, and then it's less mobile at surgery. So really the only pre-surgical embolization that I tend to do is just to take down point deep pedicles and not really the nidus itself. So I agree with that. The same thing with radiosurgery. I think across the board, the studies have shown that even with controlling for size, if you embolize an AVM before radiosurgery, the obliteration rate is lower. And I think that's because you often aren't including parts of the AVM in the plan, or you can't see something that you would have seen had you not embolized. And then the last part on transvenous embolization. So there's a trial that's currently going in Europe. You know, I think there was a recent meeting. You know, this is a widely disparate area. So I believe there was a recent meeting in South America, and maybe some of the folks on the call can kind of discuss this. But I thought, at least from the folks in South America, there had been, you know, 1 or 2 cases done transvenously at many centers, and there was almost almost 50% of the centers said that they had seen at least one horrific complication. That seems to be very disparate from what some of the other folks are saying, you know, and I've seen 2 patients this week that saw somebody else in France, and that person said, I can cure your AVM transvenously with 95 to 100% certainty. And one of them was a 6-centimeter AVM. So I was.
Yeah. Well, it's always been a discrepancy from the days of Valavanis results of 40% cure of pure endovascular. I mean, this is years ago. Valavanis, of course, is a spectacular endovascular technician, but I mean, that was degrees of magnitude more than anything doable in the US. And, you know, talking to Jacques Moret, I remember in a meeting, Jacques Moret saying he stopped treating unruptured AVMs because of the complication rate per session. I think it was 12 or 14%, the way at least he did it. And he only, in a recent meeting, just said he only treats previously ruptured AVMs. But you're right, very disparate opinions on this.
There was a SNIS meeting on AVMs earlier today, and you know, I think you get a widely disparate opinion between, you know, what you might hear here and what you might appear there. I mean, as you know, Dr. Marcos, it's pretty uncommon that we will attempt curative embolization. You know, it's usually the small AVM with 1 feeder and 1 outflow. I'm not particularly aggressive with curative embolization unless it's an AVM that's in the motor strip, that's small, that has 1 inflow, 1 outflow, that has a history of hemorrhage. But certainly around us in the community, we see that it's done over and over and over again.
Great.
Jacques, I have one question. Are you guys in US having any problem to indicate surgery for unruptured AVM after Aruba? How the Aruba trial or any other study impact in your daily practice in unruptured AVM?
Good question. Well, I guess each center is different. It really has not. The key is our neurologist understood the limitations of it and the criticism of the study. Same thing they did with the COS study. I'm doing more bypass for ischemia than I was doing before COS, mostly because our neurologists are smart and they know, you know, the limitations of those RCTs. No, I would say it has not affected. What you end up doing, you end up spending more time with the patient, explaining to them, I think if they're well educated and they know of the Aruba study, I mean, I tell them what my criticism of it, and I say, well, after this is what I recommend because of those limitations. But I mean,
the health insurance, the one who pays the bill,
yeah,
they use those trials against your indication or not?
I haven't seen that with AVM. It certainly was happening and is happening with bypass for ischemia. But I don't know anybody else on the panel has been denied payment if they operate on an unruptured AVM. I haven't seen them. Sepi, do you have that problem in Chicago?
Yeah.
Sorry?
Yeah, no, and I was going to say, I think for most people, you know, I shouldn't speak for others, but I think in general, I'm not sure that the approach to unruptured AVMs has changed dramatically by interventionalists. And I would say AVMs, it tends to be a disease that gets referred to neurosurgeons. I'm not sure neurologists are the gatekeepers to that, per se.
Yeah, well, sometimes they are. But anyway, I'd like to, if that's okay, I'd like to move on to our last panelist, Pablo Rubino, who will unmute himself and share his slide with us for the final case to be discussed. Pablo, go ahead.
Okay.
And Clemens had to leave because he had another webinar. Thank you, Clemens, for your contribution.
Okay, can you see my screen?
Yes, we see it, exactly.
Well, thank you very much for the invitation. It's an honor for me to be with
Pablo,
this,
come closer to your microphone so we hear you better.
Okay. Okay, perfect. Can you hear me maybe now?
Better, yes.
Okay. Thank you for the invitation. I like to share this case about an AVM. I came from the Hospital El Cruce. Cruce means intersection because it's between two big cities in Buenos Aires. Okay. This is a case about a female patient, 17 years old. She has a familial history of hemorrhagic stroke. She suffered a recent settlement of moderate to severe headache. This is the only symptom she had. She was in perfect neurological condition. This is the MRI. Before coming to my office, she went for 2 opinions. They already asked for an MRI and from an angiography. And they suggest just to a conservative approach. And this is the lateral view of the angiography. And then this is the AP projection of the AVM. So, and these are the options for the rest of the people who want to suggest some kind of treatment. And then I can tell you what I did.
May I ask, I'll ask Dr. Nathal maybe opinion first, then Dr. Jafar, and then we'll ask the speakers.
Yeah, well, this is a eloquent area AVM. And for me, I think this is a resectable AVM using the Hashimoto technique, as Sepi said before. And if you see the angiogram, there is only a few number of deep perforators. For me, this is the most important consideration in this kind of AVMs. Because you don't see a lot of these small vessels. Sometimes it comes from the lenticular striates arteries, but I think this could be resectable according to the symptoms. Excuse me, I didn't catch how was the presentation, clinical presentation of this patient, but I think it could be operated with the Hashimoto technique.
Only headache.
Oh, I thought there was a seizure. No, only headaches. Okay.
Only headache, recent headache.
Thank you. Jafar, is this operable in your hands, motor area?
It's a tough decision. If you
want to see the MRI, do you remember the MRI?
Post-motor on the angiogram. If I were to, I mean, on the MRI, it looks like it's sitting right in the precentral sulcus, in the motor gyrus. So it's a tough decision. What makes me push for more treatment is because of the T2 changes around the AVM, which shows there's a lot of brain swelling and reaction by the brain to this AVM. It looks like it's a high flow AVM. The other thing that would push me towards treatment is that when I look at it, it looks like there's a venous stenosis at its exit at the vein into the superior sagittal sinus. And that's why you have this this dilated vein. If I can pretty much be sure that what bothers me is the swelling T2 swelling around it. And I would therefore go with embolization and resection.
Are you not worried that embolization might create an infarct in that motor area since it'll be quite, it's so close?
I have total and complete reliance in the excellent work that my endovascular guys do. That is a very important thing to know. Our complication rate at NYU is about 3%. And you can do these, if you can do these safely, we're not gonna go and blindly embolize everything. But if you can cut some of the blood supply to the A1, I mean to the aneurysm from the anterior cerebral artery, I would go for it. they are the ones that judge it when they do microcatheterization and see what the exact angio architecture of this AVM is.
Sepi, just to please quickly your advice.
I think similar. I think what drives to want to treat this patient, obviously her very young age and therefore her lifetime risk. And then what Jafar noted, which was at least the appearance of that venous stenosis, I feel is a worrisome sign for risk of hemorrhage. I think radiosurgery, I mean, this is where we would talk about it in our interdisciplinary conference and at least talk to our radiosurgeons and say, hey, what do you think the risk benefit of that is? You know, the nidus is on the larger side. So for her young age, ideally surgery, but I think, you know, that would be a discussion to accept the risk of some at least transient deficit related to that. But as was mentioned by the prior folks, I think the idea of targeting, we would target based on flow. If we'd measure the flow, if this is high flow, we'd embolize to reduce flow ahead of time and to try and target deep feeders, and that would be the surgical strategy. But I wouldn't discount radiosurgery off the bat. I'd ask my folks who are more experienced with that to comment at least on the risk profile for that.
What bothers me is the TP changes around it. That's the only thing that I'm worried about radiosurgery making that worse.
Right. I mean, there might be some venous hypertension already going on, and as it occludes, that might worsen certainly.
Yeah. Okay. Jacques.
Yes.
Can I say something about it? I asked Pablo about the symptomatology because he's a very young patient. There is a risk for surgical treatment and also by radiosurgery. What about consideration to maintain this patient under observation and control the headache as the only symptom she had? The second question is, somebody some of the panelists have some experience with the use of propranolol as prevention for bleeding?
In AVMs, not in cavernomas, you mean?
AVMs, not cavernoma, AVMs.
I don't have any experience with that.
Because we have an ongoing study from 10 years ago. We are following patients that were not selected for any kind of treatment, only for observation. And obviously we have to wait to see the results, but at least what it seems is there is a good prevention for bleeding in the group treated by propranolol, but we have to wait to make the analysis. But I wanted to see if somebody is using also this kind of therapy for all these patients that are in the follow-up without any possibility of treatment.
Okay, Pablo, tell us what you did, because I want to leave several minutes for questions from the audience that I have to ask you guys. Okay. Go ahead.
Okay, I considered 2 points in favor to the surgery. One is the patient age, because very young. The second is the configuration of the nidus. I consider it's a compact nidus, and for me, in eloquent areas, the compact nidus is very important. My 2 concerns was the deepest part of the AVM. And this was against of surgery, and another topic was the area of the AVM. So for the deepest part, I call one of my colleagues, which is for me the best endovascular therapist in my country. He has many experience with AVM, Dr. Angelani, and he could occlude most of the AVM. For me, it was for the surgery, make the surgery easier and safer. So after embolization, we choose surgical treatment. So we just did the approach. First, I went to the interhemispheric fissure to have a control of the branches of the distal ACA. Then I moved to the sulcus, in the depth of the sulcus, and just start the dissection very close to the nidus. This is the central sulcus. You can see some hemosiderin around the nidus. It means that the patient had a silent bleeding, but my idea was it have a compact nidus with a AVM partially occlude. I can follow just the nidus in 360-degree circumferential dissection, have a very strict control of the bleeding. It means I have to keep a very clean surgical field. And I am completing the dissection. Just surrounding the nidus, and this is, I am working just surrounding the nidus, very close, without injuring the brain tissue. After completing this, I think near I already completed the dissection of the nidus. This is the nidus, and finally the venous drainage. I coagulate and cut it.
How did the patient do post-op, Pablo, immediately?
I have a picture. This is at the end of the surgery. This is the nidus. This is, I always do the immediately post-op CT. And this is the patient. The following day, you can see a very soft hemiparesis. This is the CT, the angio control. I always perform the angiography before leaving the hospital. This is AP projection, and this is the patient 15 days after the surgery, just to have the first ambulatory control. She did very well, fortunately, on recovery without any deficit. Okay.
Thank you, very nice, very nice. Any comments from the panelists? Otherwise, I will start tackling rapid fire questions from the audience. Anybody has any comments on this last case?
Pablo, congratulations, the beautiful case, excellent result as always. You have an excellent experience on that. Don't you think that you could achieve the same result without embolization, just making surgery?
Maybe I can achieve the same result, but as Professor Jafar told us, you need to work in like a team, and in this case, I can have the help of my colleague, my endovascular colleague that I know very well, and we can have a safer and easier surgery. In this case, with use of embolization. Maybe you can remove this AVM without embolization, but for me it was easier because my major concern about the AVM is the deepest part of the nidus. Right? This is the part that I have many concern when I'm doing the surgery. I already performed 180 AVMs, and in my memories, all the time I remember when I had problem was in the deepest part of the AVM. So if I can resolve this problem before the surgery, will be much better for me and for the patient.
I would do the same. I'm saying that because from your pictures, he almost occlude the whole AVM with the embolization. So when you do that, you create a higher risk in the intra-embolization hemorrhage. I agree with you that you should try to embolize the deepest part as a target in the embolization, but the result of you showed he could occlude almost all the nidus of the whole nidus of the AVM. But the result was great.
I am not endovascular. Maybe he can try a little more than I asked him for.
Yes, that's my point.
For me, it was the deepest part was perfect.
Okay, thank you. So if you don't mind, I have a list in the Q&A questions. I'm going to just pick on one person to answer it. If you...
Hey, Dr. Marcos, can I ask a question about that last case?
Yeah, sure.
Yeah, great case, Dr. Rubino. Do you consider using intraoperative motor mapping or doing surgeries awake, or does anyone do any of those elements, especially for, you know, lesions like that in eloquent territories?
I had the possibility to use some monitoring for the surgery, but I think that before the surgery, I pay attention to the nidus configuration. If you have a compact nidus and you work very close to the nidus without injuring the brain, I think that maybe you don't need. And if you have some problem when you are removing the AVM, you cannot stop, because AVM, you have to remove all of them. You cannot leave a part of the AVM. I don't want the remnant. So I think that could be useful. Even I know that some surgeons use awake surgery, but I think that in this case, microsurgical techniques and going just around the nidus is, for me, is enough.
Okay, thanks. Let me tackle some of these audience questions. Question for Sepi. How do you approach an AVM that is angiographically occluded? Do you consider it cured, or would you plan for resection to cure it? I guess you already answered this by telling of that study you looked at. Would you want to
yeah.
add
So
anything?
I guess I don't consider it necessarily cured, but it's not like we're going in after those surgically. I mean, if there was an intent to cure, which is again rare for us to attempt also, meaning that we think there's very few AVMs that would qualify for that. As Bobby mentioned, kind of single feeder, single drainer situation, and in the situation where for some reason we're not thinking about surgery as the first line. If it's angiographically cured typically, then for me it would be a matter of don't assume it's forever cured and follow it much more carefully. Otherwise, we'd be doing surgery as the primary modality with just adjunctive embo rather than trying to cure it angiographically ahead of time.
Yeah. Okay, second question. How do you treat the intranidal aneurysm? Jean, why don't you do that? Does presence of an intranidal aneurysm make you change anything about your approach to AVMs?
We have to remove the whole nidus, so it doesn't make any difference. What you can do if you are not intended to cure the patient with a high grade AVM presenting with some intranidal aneurysm, you can try to use that as a target to embolize or make a radiosurgery, because it's a risk factor for bleeding. So if you believe that you can remove the nidus, the aneurysm is coming together. But if you believe you cannot treat the nidus completely, maybe it's a good strategy to try to treat the targets with high risk of bleeding.
Dr. Nathal, I'll pose this question to you. From Dr. Marcus Rota. When to operate after embolization, right away or later? Tell us about your timing when you embolize, about your surgery.
Okay, in our institution, we operate the patients 24 or 88 hours after embolization.
24 or 48?
Yes, 1 or 2 days after embolization. There are some cases in which they embolize many times, and suddenly they say it's ready, the patient is not at the hospital, but out of the hospital, then the patient is again admitted and operated. In what I can say as conclusion, we operate as soon as possible after the embolization.
Okay. A question, I guess, back to Jean. I'm going to ask you, that you showed one of the pictures. What is the point of multiple burr holes in a craniotomy? Can you explain maybe to the junior people why you had so many burr holes in that big case? You know what I mean?
I don't have problems to remove bone.
Okay.
I have problems removing or causing any damage to the dura mater or even to the brain or venous system. So I like to perform multiple bull holes because it makes it easier to dissect the dura under. So after that, we can reconstruct with any kind of synthetic material if you have any problem to statics. Yeah. So I like to do that in order to avoid damaging the dura.
Okay. Sean, can I ask you a question about another kind of technical thing you showed? When you showed your supracerebellar approach, why go so wide on both sides? What's useful about that in getting to where you're going, rather than just
because when you perform a bilateral posterior fossa craniotomy, I like to do that because you can change your angle of approach. If you make a small craniotomy, your movement become restricted to that direction. So I can change my angle going more lateral and go to the medial aspect. So I like to do that because, especially in the case that Clement showed to us, if he performed that approach, he needs to be very, very lateral to get the most lateral aspect of the nidus. So you have to have an angle to do that. So you have to have a big craniotomy. So that's my concern about that.
Okay, let me open it up now to the panel, asking each other if there are any questions. Any of you want to ask each other any questions? Otherwise, it's been 2 hours and 34 minutes. I apologize, but it was so good. I couldn't stop you any earlier. So if there are no final remarks from anybody, I'm gonna let us all end this and go home. I really thank the speakers, the panelists. I thank the audience. We still have 200 people. We started in the 400s. Thank you very much. Ciao from Miami. Bye-bye.
Thank you, everyone.
Bye.
Thank you, everyone.
Here, good night.
Thank you.
Good night.
Thanks for having us.
Thank you.
Bye-bye.